Thank you for inviting me to give this lecture tonight for what's the first in-person event for ARMA in over 3 years. And it's kind of ironic that due to sort of MSK reasons personally for me that I'm unable to attend in person tonight. However, I'm very much there in spirit and looking forward to the conversation that we're going to have with the panel discussion. I'm Liz Lingard. I'm Transformation Lead in NHS England in the North East and Yorkshire region. And this is just an overview of the approach I think we should all be starting to think about and consider as we really do strive to make musculoskeletal care more equitable.
Just to highlight the difference between equality and equity, I'm going to use this image here that just really highlights that when we're identifying inequalities in people's opportunities to access resources and healthcare, etc., we're using a tree with apples in this situation, we can see that everybody has different needs. And if we provided just sort of evenly distributed tools, there would still be people who didn't get the same outcome, and in this case, picking the apples off the tree. So what we need to do when we've identified what the inequalities are is to customize tools that address these inequalities. So that's what we would call an equitable approach. Now, this isn't addressing the system inequalities that are present in our wider sort of communities and the wider determinants of health. It doesn't mean to say that whilst we're doing work to level up and make it a more just and fair sort of society, we can't be also turning our attention to focusing on equitable delivery of healthcare as well.
Within the NHS, there now is a national program that has the vision of providing exceptional healthcare for all with equitable access, excellent experience, and optimal outcomes. They have the 5 priorities that are there about restoring services inclusively, making sure that we're mitigating against digital exclusion, a big focus on ensuring data sets are complete and timely, especially with how we record ethnicity, that we're accelerating prevention programs, and then we're really strengthening leadership and accountability. And this is not just people in very senior positions, but it's everybody at all phases of the organisation stepping up to take a leadership role for healthcare inequalities. The core 20+5 has 5 clinical areas that aren't focusing on MSK at this time, but I think the principles of the core 20+5 are what we should be embedding into how we deliver equitable MSK healthcare. What's also good in the current climate is addressing healthcare inequalities are part of the ICB aims, as well as the NHS really embracing this role at 3 levels as a commissioner and provider of healthcare, as a partner in these integrated care systems, but also as an anchor institution role and how these institutions contribute to the wider determinants of health.
So who is most at risk of facing health inequalities? We all know the protected characteristics because it's embedded in our equality, diversity and inclusion training that we all do as StatMan training. But it's important to go further than this and recognise that socioeconomic status also plays a big part in terms of who is facing health inequalities. People who are living in more deprived areas are also more likely to live in poorer quality housing or overcrowded housing. They're less likely to have access to good income as they might not be able to find work, or they may be limited in the work that they can do. There's a lot of people living in these areas now who are employed on 0 hours contracts, and they really struggle to have flexibility in their working day to access healthcare. And also these people have often had lower levels of education, so they really struggle in terms of literacy and health literacy. But there's a much wider group of people who also face health inequalities, and these are sort of the wider health inclusion groups that we speak about. So for this is people who are clinically extremely vulnerable, and in terms of the MSK community, these would be people with inflammatory arthritis who are on immunosuppressant medication, who had to shield during the COVID pandemic in the early days and are still really struggling to come out and access face-to-face services as well. So we need to consider all these groups, and we also need to consider how they intersect as well. These factors don't happen in isolation, and where they all come together, they can really disadvantage people to actually really struggle in terms of how they access healthcare, but also the experience and outcomes they have following that care. So when we're considering the role that deprivation has to play, it also helps you get the context of the other factors that will affect how that person lives and works, and how that affects the way that they therefore manage their conditions when they're not with you in the home environment. So when we're looking at deprivation, we use these indices of multiple deprivation that ranks very small areas in England from most to least deprived, and it takes into account these wider determinants such as income and employment, as well as education, health, crime, and the living environment. So if we ranked every small area in the country and then split them into 5 even groups, nationally, you'd have a similar population in each group. But you can see here, if we look at who's living in those deprivation quintiles by region, this varies between the regions across England. And if you take, for example, the northeastern Yorkshire, where I'm from, just over 30% of our population live in these most deprived neighbourhoods. And within northeastern Yorkshire, we have wide variation as well that ranges from only 4% of people in York living in the most deprived areas to 55% of the people living in Hull who live in these very deprived areas. We also know that COVID shone a harsh light on the inequalities that we see that come from our ethnic minority communities, and that therefore led to a King's Fund report that looked at the health of people from these groups in England. And although it was considered that the access to primary care was generally equitable, it was less consistent in other healthcare settings. And we also know that people from ethnic minority communities often report being in poorer health and having poorer health experiences when they're using healthcare services if we compare them to their white counterparts. So there's a real need for us to understand what are the factors that are driving this, and to co-produce the services with these communities so that we make sure that they're culturally competent services. And one of the biggest issues that affects the access people have to healthcare and how they can engage with healthcare professionals is their level of literacy. And increasingly, as we move to systems that are digital by default, we know that some of those will be exclusive by design. So people are often quite shocked to see this slide because it shows that on average, just over 60% of the population in England finds written health information too complex. And this is a combination of sort of text and numeracy. And we know that there is a regional variation here as well, with people in the north tending to have poorer levels of literacy than the southern counterparts, with the exception of London, which has the worst overall rates for health literacy. We also know there's been real challenges around digital, not just in terms of people having access to devices, but actually being able to independently get on the internet themselves and be able to navigate the pages, to use the resources that are there. And there's an affordability element here if you're actually downloading apps or joining a Zoom class, for instance, where you have to use up data as well if you don't have contracts that are unlimited during this time. There is a real cost pressure on people. So a lot of these things aren't really affordable and accessible to our communities. And we know that there's a real divide between our most deprived and affluent communities. If you look at this, when they've done studies to look at how people interact not only with written materials, but also in terms of verbal consultations with doctors and nurses, you can see here that it doubles in the deprived communities, with much higher rates of them being able to fully engage with that information. But quite, a shocking statistic also to see that sort of 10 to 15% of people in our more affluent communities also say they have difficulty with written and verbal conversations. So why is this important for musculoskeletal conditions as well? And just sort of show this slide that highlights some very high-level sort of epidemiology of musculoskeletal conditions. First of all, these are really common conditions. You know, even though we think of inflammatory conditions and osteoporosis as being less common than things like back pain and osteoarthritis, when you put them up against other long-term conditions like COPD and diabetes, these are very common conditions. And we know the risk factors that are, documented to be linked to these conditions are very similar risk factors for other long-term conditions like diabetes and cardiovascular disease and COPD, for instance. And we also know that these risk factors are more common in our more deprived communities. So it's a perfect storm of knowing that these are conditions that we're more likely to see in our more deprived communities. As I said, they're very common. 3 in 10 people in the UK have musculoskeletal conditions. We know they increase with age and that they're more common in women than in men.
This slide's courtesy of George Peat and colleagues he was working with at Keele University, that looked at MSK consultation rates in sort of more deprived areas versus the less deprived areas. Now, this comes with a bit of a health warning. It's only as good as the data that's in the GP research data set. However, what we can see, if we're looking at consultations for low back pain, there's a 50% increase between the least and most deprived. And when we're looking at osteoarthritis, there's a 30% increase in consultations between the most and least deprived there. And there's quite a lot of regional variation with higher consultations in the north compared to the south. And this mirrors roughly what we'd expect the epidemiology to be of these conditions.
So it's important for us, if we're addressing health inequalities, that we take a life course approach with a greater focus on children and young people, what we can do to change those risk factors and change their behaviours so they have healthier lifestyles, so we mitigate and limit the level of some of the preventable musculoskeletal conditions as they go through the life course into working age adults and then into older age as well. And that we're also addressing health inequalities across the care pathway, from prevention to highly specialised care. So as a first contact practitioner, you'll see people presenting with mild conditions, as well as presenting potentially with undiagnosed inflammatory arthritis, where you need to rapidly get them into specialist services, as well as more sort of long-term musculoskeletal chronic conditions as well. So for all of these different ranges of conditions, we need to be thinking that we're always looking through a health inequalities lens for what we're doing to make sure that we are customizing the tools, we're customizing the treatment, the self-management support, everything that we do to make sure that we're addressing those underlying health inequalities. So if we are going to deliver equitable MSK health services, what we need to do is understand all the groups who are accessing services who are most at risk of health inequalities. So not just protected characteristics, also those living in deprivation or potentially remote and rural areas, as well as those wider inclusion health groups. That we take a population health management approach. So that's where you consider not just the people who are coming through your door, but everybody that lives in the catchment area of where your service is. So that you're thinking, are people coming to the most appropriate place for service, or are they accessing services in an inappropriate place? For example, we know that the activity in A&Es for MSK conditions is much higher for our most deprived communities than it is for the least deprived communities. Yet when we look at secondary care activity in terms of outpatients and going in for elective care operations, that difference almost disappears. We know the need's greater for people from more deprived communities, but it appears that they're presenting a lot more into sort of A&Es and things inappropriately. So it's trying to understand that, to think about how we take a population health management approach to redirecting them into more appropriate services. And it's really important that we co-produce this, so that if we're putting in place evidence-based interventions, We're making sure that they're going to be delivered in an acceptable, accessible and affordable way, and that we've considered all those other factors that I've spoken to you about, health literacy and digital inclusion, etc., and that we're making sure that they're culturally competent services. And this may require us to unequally weight or target the services, because what we're looking for is this proportionate universal approach. So there's a universal offer, but it's proportionate to the needs of the community or the population that we're serving. And that if we have got these specific groups that we know are at greater risk of health inequalities, that we're targeting the interventions to them as well, or we're putting in additional support to help them engage with what might be digital tools or other sort of patient management tools that are written materials. We need to make sure that we're doing some public-facing comms, and again, we co-produce these with the communities as well. And none of this has to be done in isolation or on your own. There's lots of people working in the NHS in regional and local teams, as well as public health colleagues, either in the what was formerly Public Health England, now as the Office for Health Improvement and Disparities, and local authorities and our wider partners like the academic health science networks, who are there to help if you don't fully understand these issues, to help to co-design these services.
I think it's important to also reflect on what we can do as individuals, as a member of a team and as a member of an organisation to really reduce health inequalities. I think this is the only way we're going to challenge ourselves to create the optimal sort of environment for this to happen, so that we really are constantly reducing health inequalities by really listening to those who've got lived experience to help us find these solutions. And for those of you who are listening or know people who have had experiences where they have had a poor experience of care because of an inequality that they have, really keen to hear those stories, so that whether it's an individual or family or friends that have experienced this, or a wider community, it's very important that we find safe places to hear these stories and use that to co-produce solutions. So before we embark on any decisions and how we're going to move the agenda forward, there needs to be that time where we take the time to ask these questions and have this discourse. And this is sort of part of what's happening tonight and shaping what happens in the next 12 months as well, to make sure that what we're doing isn't inadvertently widening health inequalities as we go in our ambition to reduce them. Just wanted to also pop in that sort of King's Fund tool. I think it's a great tool just to give people the basics. I know it's been developed for allied health professionals, but it really does have some great, very simple advice on how to raise awareness with individuals, how they can take action and how they can be an advocate, regardless of what level in the organisation they are. So really now it's a time to sort of get involved and make a pledge to listen, learn and level up. It would be great if people were pledging to do things today that will help make a difference. If they're already doing great work, then shout out and let us know so that we can share it. And if you need help and support and want to link in with people and network, again, we want to help make those connections. And this is a real opportunity to do that with a fantastic organisation like ARMA to support you. Thank you for your attention.